I am Dr. Ashish Dagar, and today I will be discussing about indications and rationale for artificial disc replacement, particularly in lumbar spine. In cases of degenerative disc disease, we usually start with a conservative management, and if it fails, then we go to different modalities. And as the symptoms progresses and the patient is not cleared with these interventions, we end up with option of only two things. Either we go for fusion, or then there is a option of a total disc replacement in such type of cases. Coming to the fusion first, we all know fusion has some disadvantages, which include need of a bone graft. We might need to harvest it from autogenous sources, or we might need an artificial bone graft. There are chances of pseudoarthrosis when we are going for fusion. And once we have fused a segment, it is fixed for lifetime. We cannot alter it. And if it is fixed in a malalignment, the patient has to live with it. Then there is a case of adjacent segment degeneration, which we know that after fusion, the adjacent segments, they usually degenerate as the time progresses. There are different clinical studies which are there, which shows the significance of adjacent segment disease. This study published by Jean et al., they showed that there are incidents of around 42% of radiologically significant adjacent segment disease after fusion in lumbar or thoracolumbar spine. But they also showed that the clinically significant adjacent segment disease that ranges at around, the incidence ranges at around 30%. And most of the most common symptoms of clinically significant adjacent segment disease include spinal stenosis and related symptoms like back pain and radiculopathy, back pain related to instability, and sagittal and coronal imbalance. Paul et al., they did a meta-analysis which included 25 retrospective studies. They also showed that radiographic ASD, the incidence ranges from 5.2 to 100% in some of the studies. But the clinically symptomatic adjacent segment disease, the incidence ranges somewhere between 5 to 18%. So why does this happen with fusion? Biomechanically, we know that fusion increases the intradiscal pressure, increases the facetal loading, and causes hypermobility at the adjacent segments. Some of the risk factors which increases chances of ASD are use of pedicle screws, facet joint violation during surgery, sagittal malalignment, and large fusion lengths. Punjabi et al., they did a cadaveric study to test effect of fusion and artificial disc replacement. They did this study in cadaveric spine with flexion extension, lateral bending, and rotated movements. With two-level fusions, they determined that the increase in adjacent level pressure was ranging up to 35% increase as compared to the normal spine. While with two level of total disc replacement, the adjacent segment pressure changes were as comparable to an intact spine. In cases of a hybrid in which they did one level fusion and the adjacent level total disc replacement, the values were comparable to the single level fusion. So this shows there is a significant rationale to go for total disc replacement, and these rationales include total disc replacement helps us to maintain motion and spinal balance. It decreases the chances of development of adjacent segment degeneration, and it doesn't rule out fusion. We can anyways go for fusion if somehow this surgery fails. Total disc replacement, as we have seen with cadaveric studies, it reproduces the native kinematics of the spine. The normal range of motion and instantaneous axis of rotation are maintained while after doing total disc replacement surgeries. Coming to the indications, when these devices were tried for the first time, these are the indications that the FDA verified. So the inclusion criteria for FDA trials were age somewhere between 18 to 60 years. In a patient with a symptomatic degenerative disc disease, usually with a single level. This single level might range from L3, L4 till L5, S1. Patient should have a oswestry score of more or equal to 30, VAS score 40 or more out of 100, and uh, there should be a chance of conservative management should have been given to the patient for around 6 months. There should not be a significant nerve root compression causing radiculopathy. And there should be less than 3 prior abdominal surgeries. This is because of the access is required when doing disc replacement is from the abdomen. But over a period of time, there have been some extended indications and there have been the changes in the indications that we can use now. So at present, minor facet changes are not a contraindication and we can proceed with this total disc replacement in such type of cases. If patient has undergone previous discectomy and we have not destroyed the bony anatomy, we can still go for total disc replacements, even if the age of the patient is more than 60 years. But and he is fit for in another criteria, we can go for a total disc replacement. In smokers, we have to just check for osteopenia. If the bones are good enough, we can go for total disc replacement. So up to grade 1 and 2 facet arthropathy, we can choose total disc replacement, but with higher grades of facetal arthropathy, we need to go for fusion rather than total disc replacement. The exclusion criteria of the FDA trials included previous fusion surgery, any previous fracture at the level of interest, osteopenia with T-score of less than 1 minus 1.0, and a metabolic bone disease, spondylolisthesis of 3 or more mm, scoliosis of 11 degrees or more, facet joint arthrosis, morbid obesity, allergy to the metal, autoimmune disorder, and very important thing, psychological disorders causing back pain. These were the exclusion criteria and they still stand, except the facet joint. Coming to the outcome, so when these trials were started, the short-term outcomes were the TDR, the group had the same, and if the results were same and as effective as the fusion. And some outcomes were superior on some measures. Richard et al. Published 5 years follow-up with 90 TDRs and compared to 43 LAs during the same period. The range of movement was maintained in total disc replacement cases, and TDR had significantly greater return to work with fewer patients in long-term disability. Coming to the 10-year follow-up cases, the TDR group showed more than 90% excellent outcome, more than 90% return to work, and range of movement was maintained in more than 95% cases. Adjacent segment disease after total disc replacement. So James et al. They reviewed 25 studies and they found out the 31 cases out of 313, that comes around 3%. They developed adjacent segment disease as compared to 31% cases of, in case of fusion who developed adjacent segment disease, and the p-value for this study was positive. So in summary, we have a strong data to support safety and efficacy of total disc replacement. Since 2006, there have been more than 15,000 cases of total disc replacement done around the world with less than 0.5% revision rate. There are multiple randomized controlled trials with 5 to 10 years of follow-up. Total disc replacements results are as good as fusion and superior on some measures. Total disc replacement is similar in cost to fusion or is less expensive, particularly in ALIF cases. With total disc replacement, we have got best cumulative scientific evidence comparable to any technologically developed implant in the human body, be it artificial hip replacements, knee replacement, plates or screw. We have to just trust the data and adopt this technology. Thank you.